Hello everyone. I am back again to be with my surgical colleagues and friends. Today we are going to talk about prevention of surgical site infection, which is the infection which occurs within 30 days of the surgery or within 1 year of any implant being put in the surgeries, and it occurs at the surgical site or in the deeper tissues. So let us discuss how to really go about it to become the masters. So I would just say to my surgical colleagues and friends to own their OTs, to own your OTs, meaning you must have the awareness and knowledge about what is the design of the OT where you are going to operate your patients. So first and foremost thing is to know what type of OT it is. For super specialty OTs, that is for super specialty surgeries like orthopedics, neurosurgery, cardiovascular surgery, oncosurgery, the OT needs to be class 100 or ISO class 5 OT. For the general surgery, the OT needs to be class 1000 or ISO class 6 OT. Second point is about the air handling units. It is recommended to have dedicated air handling units for each operating room in an OT complex. In case, and especially so for all the super specialty surgeries, in case of general surgery, if for some reason it is not feasible to have the dedicated AHU for each operating room, then one needs to keep in mind that if in one of the OT any infected case is done or any growth occurs in that OT, then no case can be taken up in other OTs which have the common AHU with this infected OT, until and unless this infected OT is disinfected and sterilized. So one has to keep in mind about the option of the alternative OT in such situation. Third point is about having the positive pressure of 2.5 Pascals in the operating room, so that whenever the operating room's door is open for some mandatory work, the air goes out from the operating room to the semi-sterile area and not from semi-sterile area to the sterile area of the operating room where the surgery is exactly going on in operating table. Fourth point is about the temperature. A temperature of 21 degrees centigrade plus minus 3 degrees centigrade needs to be maintained to prevent the growth of bacteria in the environment. And except for the joint replacement surgeries where the temperature needs to be 18 degrees centigrade plus minus 2 degrees centigrade. The relative humidity has to be between 20 to 60% and the ideal is 55% relative humidity. The air changes need to be minimum 20 air changes per hour. The HEPA filters need to be installed for filtration of the air, and these needs to be changed at least annually when the dope test is okay at 6 monthly interval. If the dope test is not being done, then this needs to be changed earlier as per particulate counts and then normally recommended at 6 months. So once you are confident enough that where you are going to operate is safe for your patients, definitely when the patient comes to your OPD, you are more confident. And as an expert, you are doing all the pre-operative work with your anesthesiologist colleagues. Two important points which I would like to stress upon is the throats. One is the throat swab in the oral surgeries, especially so in oral cancer surgeries, because besides, if the patient is carrying any persistent infection, it may lead to surgical site infection. More so when the anesthesiologist intubates the patient in the operating room, this leads to migration of that bacterial growth into the respiratory system of the patient, and this leads to respiratory infection in the patient, which may be dangerous at times. Second point is about educating your patients about the preoperative bath with the chlorhexidine. This is normally recommended to have a preoperative bath 2 to 3 days prior to the date of the surgery. Once the preoperative assessment has been done, all the investigations are okay. Of course, the importance of euglycemia is cannot be negated, because hyperglycemia is another factor which may lead to surgical site infection. Once the patient is admitted in the ward, the preoperative bath needs to be given in the night of the surgery, a night prior before the surgery, and on the day of the surgery, morning of the surgery. If the bath cannot be given, then the sponge bath needs to be given. Second point which needs to be kept in mind in ward is about the antibiotic prophylaxis. So all the surgical colleagues definitely are the expert about which antibiotic to be given, what dosage to be given. One important point needs to be remembered is about the timing of the antibiotic prophylaxis, and that is why this needs to be given in the OT complex or in the operating room, because the best timing is supposed to be within 1 hour of the incision time before the surgery has started, so that to have the peak concentration and it prevents the surgical site infection. This antibiotic dose, the prophylactic antibiotic dose, this needs to be repeated in 2 situations during the surgery. One, if there is a massive blood loss, so that because the antibiotic loss occurs from the body, so this needs to be repeated, or in case of any long major surgeries. And one has, for this the surgeons and the anesthetists all have to know about the half-life of the antibiotic. Let's say if the surgery is for 5 hours and the half-life of the antibiotic is 4 hours, then the antibiotic needs to be repeated at 4 hours on operating table. Another point is prevention of hypothermia in patients. We have talked about the maintenance of environmental temperature around 21 degrees centigrade plus minus 3 degrees centigrade for all surgeries, and for 18 degrees centigrade plus minus 2 degrees centigrade for joint replacement surgeries. But what about the patient? It has been known that mild hypothermia leads to increased risk of surgical site infection, and hence the usage of IV fluid and blood warmer becomes important in case of major and long surgeries, and the usage of warming blankets. This is mandatory in the OT as well as in the recovery area also. Once the surgery is done and the patient is shifted to the recovery, and then from recovery to the either ICU or the ward, here I would again say the second area which the surgeons have to really own something else, that is, I say, is the dressing trolleys. Surgeons are expert in each and everything. these trolleys are being maintained by our nursing team. But owning our dressing trolley means one has to be aware that it is properly being cleaned, the dressing trolley is being disinfected, and the disinfectant kept on the dressing trolley are not expired ones, the shelf life has not got over, and they are sterile gauze pieces, the instruments, the gloves are there, sterile gloves are there. So that's where I say on the second area, own your dressing trolleys. So once everything is done, of course, the patient will be discharged. And once the patient is discharged, now comes the role of follow-up. Even if the patient is not coming in the OPD, it's the responsibility of the hospital staff, nursing staff, along with the surgical team to follow the surgical patients. And of course, the surgeons are leaders into that. They own their patients here also, that the tracking has to be done whether the patient is having any signs and symptoms of surgical site infections, then they are accordingly taken care of. That has to be kept in mind for 30 days in all surgeries, and in case of implants for 1 year. To know more in details and to have more insight about prevention of infection in the operating room, please read my chapter which I have authored in Yearbook of Anesthesiology, 9th edition, and this is available as hard copy on Amazon and also as an ebook. So stay tuned for more knowledge sharing. Looking forward to